Assalamualaikum and very good morning everyone. Welcome to the Faculty of Medicine Weekly CPC, and this week is actually the Department of ONG is turn to be the host. And for those who are logging in from outside UKM, welcome to our weekly meeting. So this morning, we will present to you a very interesting case of a woman who had vaginal bleeding during the antenatal period. So my name is Prof. Nur Azura. I'm the head of Department of ONG. So we have lined up 5 great presenters this morning to walk you through the scenario of this lady. So the first presenter is Dr. Rafi. He is our final year master student. He will present the history and also the progress of this patient. So with that, I'd like to invite Dr. Rafi to go ahead with the presentation.
Thank you, Prof. Azura. So, a very good morning and Assalamualaikum to everyone. I'll start with the case of this patient, a pregnant woman with vaginal bleeding antenatally. So this is the outline of my presentation. I'll start with the introduction to the patient and I'll touch a bit on the imaging part and the management and also the surgery that was done. So patient is Madam T. She is 38 years old, Gavra 6, Para 2 plus 3 at 36 weeks, 3 days period of amenorrhea at the time of the delivery. So antenatally, she had 2 previous scars and this is an actually IVF pregnancy. So she did her IVF in Sanford Fertility Center. Subsequently, she booked and dated her pregnancy in Britannia Hospital. All her booking parameters were otherwise normal, with blood pressure of 94/68, pulse rate of 80 beats per minute, weight was 65, height 160, and BMI of 25. She was non-proteinuric and non-glycosuric. So she first presented to our center at 28 weeks gestations, whereby she was diagnosed to be having placenta previa type 3. Otherwise, she was at the time asymptomatic and planned to be seen again in 2 weeks. So at 30 weeks, she had the first episode of pervaginal penniless bleeding. Otherwise, her fetal movement remained good and she had no recent trauma and she doesn't have any recent sexual intercourse. So at the time, patient complaining of soaking quarter bed sheets and panties, which was an estimation of 100 cc blood loss. Otherwise, she doesn't have any abdominal pain. She doesn't have any contraction. No leaking liquor, no urinary symptoms, and she doesn't have any pervaginal discharge prior to the event. She also doesn't have any recent sexual intercourse. Fetal movement is otherwise well perceived and good. So at this point, we were thinking about what was the diagnosis. So when patient presented with antenatal vaginal bleeding, 4 main diagnoses will come to our mind, with the first one being bleeding placenta previa. Second one is bleeding previa with placenta acquita spectrum. Third is abruptio placenta, and fourth is local causes, which is involving cervix and also vagina. So for bleeding placenta previa, usually the point that can favor in the diagnosis would be history of painless bleeding, or any diagnosis of previa prior to the presentations. And clinical examination will usually shows soft abdomen with no evidence of presence of uterine contractions. And ultrasound examination will shows presence of low-lying placenta. So in the event if the patient presented with painful bleeding, it is a point favoring against the placenta previa diagnosis. So for the diagnosis of bleeding placenta previa with placenta acquita spectrum, basically the presenting complaint will be the same, and in addition, patient will have risk factor for acquita such as history of prior cesarean deliveries, uterine surgeries, or A1 age. And clinical examinations will usually shows the same thing, which is soft abdomen with no evidence of uterine contractions. And usually the investigation, which is the ultrasound examination, will show the same features, which is low-lying placenta with evidence of placenta acquita spectrum features. So for the diagnosis of abruptio placenta, usually patient will be presented with painful pervaginal bleeding, and history of prior trauma to the presentation will support the diagnosis, together with presence of any risk factors such as hypertensive disorder, polyhydramnios, multiple gestation, chorioamnionitis, maternal nicotine or drug abuse, and also thrombophilia. Clinical examination will usually reveal presence of tender abdomen, board-like rigidity, and in the case of massive concealed abruption placenta, sometimes we can see presence of retroplacental clot on ultrasound assessment. So for diagnosis of local cause, which is involving vagina and also cervix, patient will usually presented with painless bleeding, similar to placenta previa presentations, and sometimes they can have a complaint of provaginal discharge. And clinical examination will usually shows evidence of inflamed cervix or cervical mass and atropions, and the abdomen will usually be soft with no evidence of contractions. And ultrasound assessment usually will shows the presence of upper segment placenta. So for this patient, upon our examination, she was not pale. Her hydration status was good. Abdomen was soft. Uterus was 30-week size, which was appropriate. It was a singleton pregnancy in longitudinal lie, and it was Catholic presentation with 5/5 palpable. Estimated fetal weight was 1.4 to 1.6 kilogram. There was no contraction on manual timing, and there was no scar tenderness. Speculum examination shows normal vulva and vagina. Cervix was healthy. There was only minimal blood seen and no discharge. So we sent a few biochemical parameters. ABC showing good HB level of 11.4 with white cell of 5.9 and platelet of 202, which was normal. Coagulation factors was also normal, and urine FME shows no evidence of any urinary tract infections. So we supplemented her with ultrasound assessment showing singleton pregnancy in Catholic presentations with appropriate parameter and estimated fetal weight of 1.5 kilogram and presence of placenta previa anterior type 3. So for this patient, in view of presence of risk factors of 2 previous scars, placenta previa together with A1H, according to studies, this patient has 11% risk of developing morbidly adherent placenta. That's why during the ultrasound assessment, there are a few features that we try to look to diagnose the presence of placenta acuta. So in these patients, the features that we can see is the abnormal placenta lacuna presence. So we can see that there were presence of numerous lacuna on Doppler ultrasounds containing turbulent flow visible on the grayscale imaging. The second features that we can see in this patient's imaging is the bladder wall interruptions. As we can see, there's the loss of bright bladder wall, and there are features of loss of clear zone together with features of uterovesical hypervascularity. So all these features are suggestive of presence of morbidly adherent placenta. So the diagnosis was made. Patient was treated as bleeding placenta previa with placenta acuta spectrum. So afterwards, she was nursed in our HDU. She was kept in BM and she was given IM dexamethasone to accelerate the fetal lung maturity in anticipation of early delivery. PITS team was also informed and ABC and GSS was sent. So the bleeding stopped after about 48 hours. She doesn't have any more provaginal bleeding since then, and she was managed expectantly in the ward until delivery. In the ward, repeat ultrasound assessment was also performed, and she underwent MRI assessment altogether. So serial growth scan shows the baby is growing well, and the placenta remain previa type 3 anterior with suspicious of increta. Her HB remained good, ranging from 11 to 12 grams, and she was maintained with hematinics. Patient was also managed with multidisciplinary approach involving the blood bank team, anesthetist, and also neonatologist teams. So for the management for this patient, for the pre-delivery preparation is include the steroids, which I mentioned before, hemoglobin optimizations, blood products backups, multidisciplinary approach, early anesthetic evaluation, ICU backups, and also internal iliac balloon catheterization prior to cesarean sections. We also include bowel preparation prior to surgeries and early timing of delivery. So for the intraoperative consideration for this patient, we stand by her with 4 pints blood products in anticipation of postpartum hemorrhage. There was a blood rapid infusion machine ready during the surgeries, and all team were on standby during that time. Patient was also put in supine positions. And for the approach to the surgical approach, after lengthy discussion was made with the couple, we decided to do a fenestrial skin incision, classical caesarean section, and also immediate hysterectomy. So this is the intraoperative finding. Before we send the patient to operation theatre, internal island artery balloon was inserted by our respected IR team, and patient was sent to OT afterward. So if, as we can see from the pictures, the lower segment is very vascularized. There was a bluish discoloration of placental bulge that we can see on the lower segment. So classical caesarean section was performed and baby was delivered as breech. Intra-umbilical hemabate was given. However, there was no signs of placenta separation. Thus, we decided for hysterectomy. Internal iliac balloon catheter was inflated after the delivery of the baby, and uterus incision was closed before we removed the uterus. So bladder during the operation was high. However, we managed to push down after dissecting the uterovesical fold, and there was a presence of lower uterine segment ballooning since after we dissect the uterovesical fold. Placenta was seen invading up to the serosal layer, which is suggestive of placenta increta, and hysterectomy was performed afterward. So we did a careful dissection of the lower segment in these pictures, and bladder was pushed down. Alhamdulillah, the estimated blood loss during the surgeries with the aid of the balloon catheter was only 500 cc's. And there was no blood transfusion needed. And balloon was removed by the IR team after the surgery, and patient was monitored in our HDU for 1 day and subsequently transferred to ward. She was discharged well at the day 2 after surgery, and baby has good outcome, weighing 3.1 kilograms. So this is the uterus after removal. So we can see that the placenta invading up to the serosal layer from these pictures. So postpartum period, patient was discharged well after day 2 of post cesarean section. She was reviewed again in 2 weeks and then 6 weeks time, and she remained well. So histopathological examination shows consistent with placenta previa with increta. Thank you, Prof.
Thank you, Rafi. All right. I would like to invite Dr. Erika, Doctor, to explain about the radiological finding of this patient. Dr. Erika is our radiologist. She's currently posted in HPKK as her main interest is in pediatric radiology. So with that, I'd like to welcome Dr. Erika.
Thank you, Prof. Can I share my screen? Wait, Right. I hope you are seeing my screen now.
Yes, we can see your screen, Erika.
Okay, thank you, Prof. So, good morning. I'm Dr. Erika from the Department of Radiology, and I will be presenting on the MRI of this patient. So this MRI was done at 32 weeks and 2 days of gestational age. And this image shows two of the T2 sagittal MRI placenta. So we can see a singleton fetus with cephalic presentation. This is the head here, so cephalic. And when you look at this is the placenta, which lies predominantly anterior and also is low-lying. As you can see that part of the placenta actually covers the internal os. This is the cervix here, and the part of the placenta is covering the internal os over here. So this is a placenta previa, type 3 anterior, all right? And over here, you can see an arrow pointing towards the place where the placenta actually bulges out. Yeah, so there's a bulging, focal bulging of the placenta at the anterior aspect. And this is the myometrium layer, which is slightly brighter than the placenta. And you may see that at the place where it bulges, or there is relative thinning of the myometrium at this level. So, but there was no invasion of the anterior abdominal muscle. And this finding raises suspicion of myometrial invasion, which is at least placenta increta. right? And at the lower part here, and when we look at the placenta itself, it appears slightly heterogeneous. In a normal placenta, we would expect it to be homogeneous. However, as the placenta ages towards third trimester, usually it becomes more heterogeneous. So in this case, it is very hard to say because it's done at 32 weeks, which is already in the third trimester. It is slightly hard to tell whether this is a normal aging of the placenta or it's something more abnormal. Okay, unless the heterogeneity is very severe. So this is just mild to moderate heterogeneous placenta. And this arrow here points towards the caesarean scar, the previous caesarean scar. And we can see that at the level of the caesarean scar, there was no abnormalities seen in the underlying placenta. In the third trimester, usually lower segment myometrium is very thin. So most of the time, you can't see the myometrium anymore. And that makes assessment of placenta invasion a bit more difficult. So, but there was no other secondary signs like intraplacental bands or abnormal vascularity at the level of the caesarean scar. So it makes placenta invasion less likely, right? And in the next slide, this is axial cut. So this is cut at the lower part of the placenta where we see two T2 dark intraplacental bands. These are fibrin, supposed to be fibrin bands caused by hemorrhage and sometimes caused by infarct. So they are not specific for placenta invasion and sometimes can be seen in other conditions. But when they are present in a larger number, then it makes placental invasion very likely, right? So presence of these raises suspicion of placental invasion. And this is coronal scan in T2, and on the right side is sagittal view. So this view shows almost collapsed bladder, which is not very ideal for bladder wall invasion assessment. But over here, you can see a little bit of irregularity or nodularity where it seems like as if the placenta has some invasion into the dome of the bladder. And on sagittal view, again, we see similar findings where the dark bladder dome outline was disrupted anteriorly for a very small area, and adjacent to it there was the T2 placental dark band. Okay, so with two signs at the same area, then it makes placental invasion more likely. And because there is disruption in the sign of in the signal of the bladder dome wall, we suspect that there could be bladder wall invasion. So that means the placenta has actually invaded out into the adjacent bladder, and this makes the placenta precreta a possibility. But bear in mind, because the bladder was not fully distended, so sometimes it can appear a little bit irregular, and it makes bladder wall assessment also a bit more difficult. So in this case, that was the limitation. So the impression for this MRI was placenta previa, type 2 anterior, and with presence of intraplacental dark bands, these are suggestive of placental invasion. Subtle disruption of bladder wall signal may indicate bladder dome invasion, which makes placenta precreta a possibility, but this appearance can be due to inadequate bladder distension. So especially when there was no other signs, we don't see increased vascularity around that region, and there was no other signs to suggest the placenta invasion. So a little bit about placenta acquita spectrum, previously called morbidly adherent placenta. This is abnormal placenta adherence or invasion of the myometrium or extrauterine structures. It encompasses three conditions from less severe to more severe: placenta acquita, increta, and perquita. Two major risk factors are present: prior cesarean section and placenta previa, which our patient have both. Okay, and this condition can be associated with massive bleeding during manual removal of placenta post-delivery, and with increased maternal morbidity and mortality. That's why it is important to diagnose. It is primarily staged and managed surgically, and imaging aids in preparation of surgical complexity in some cases. This is a schematic drawing showing you the different types of placenta accreta spectrum. This is normal one, and this is accreta, where you see the placenta already invading into the decidua basalis, attaching onto the myometrium, but not yet invading myometrium. In increta, the placenta invades into the myometrium, but does not penetrate it. And in percreta, it has already reached the serosa and gone outside from the uterus. So this is the most severe. In imaging of this placenta accreta spectrum, ultrasound has an overall sensitivity of 90% and the specificity of 83%. These are indices from quite a recent meta-analysis. So ultrasound is a primary and first-line imaging in all the cases. Okay, MRI has a similar overall sensitivity to ultrasound, 89%, and the specificity is just slightly higher, 87%. It is the next level imaging when ultrasound is equivocal, and especially used to evaluate areas which are difficult to visualize on ultrasound. For example, if the placenta is posterior or lateral, and there is a suspicion of lateral invasion into or surrounding invasion into the rectum, parametrium, or pelvic side walls, then MRI is good for it. Right. So optimal window for MRI placenta is 24 to 30th weeks of gestation, meaning usually second trimester is the best time for you to do MRI placenta. The reason being, when you do it less than 24 weeks, placenta is immature, and the proliferation of vessels at the placenta myometrial interface cannot be differentiated from signs of invasion. All right. And if you do it more than 30 weeks, as in this patient, the placenta becomes very heterogeneous. So it makes differentiation from placental invasion signs difficult. And the myometrium layers becomes very thin and less distinct. You don't see the 3 layers clearly. And sometimes in the lower segment, they are so thin until you cannot see any myometrium almost, right? So it makes a placental invasion assessment difficult in third trimester, especially when it is very near to term. So the accuracy of MRI findings becomes low. If you do the MRI placenta more than 30 weeks, then you need to correlate it to findings on ultrasound, because sometimes ultrasound can be more accurate later. So this is an example of normal placenta showing a very homogeneous placenta, and this is the placenta myometrial interface, which is hypo, which is dark on MRI. So if you see this, you know that the placenta doesn't really invade into the myometrium, and you have some small vessels here, and the edge of the placenta is tapering, not bulging. And here in axial cut here, we can see 3 layers. This is the placenta. This one is the myometrial placenta interface, which is dark. This more brighter layer here is the myometrium. Okay, we see this a bit higher up, so that's why you can see the layers very clearly. And then the dark band, which outlines this myometrium, is the serosa. So in this case, we can see all 3 layers clearly, then you can clearly tell where the placenta ends. But when all these are not seen in third trimester, then the assessment becomes difficult. So this is an example of placenta accreta in another case, not our case. This shows a very obvious placental focal bulging into the lateral aspect of the myometrium and focal thinning. So this one, the hyperintense one, is a myometrium. You can see that it is thinned out. So it means that the placenta has already invaded into myometrium, and this is placenta accreta. It has not gone through the serosa yet. Right? And this is another example of placenta accreta, where you can see that there are dark intraplacental bands and invasion of placenta to the anterior abdominal wall. This is the sagittal view, anterior abdominal wall, and it attaches. The same thing is seen on axial cut. So these are suggesting that the placenta has already gone through the uterus and went to the anterior abdominal wall. At the same time, you see the bladder being tented. So this is the dome of the bladder, which is pulled up, which also suggests that there is bladder invasion, right? So pitfalls, over here you can see that the highlighted findings such as uterine bulging and the heterogeneous placental signal, they have the highest specificity to diagnose PAS, okay, placenta accreta spectrum. But these two are usually easily confused with third trimester normal findings. So that's why when the MRI is done late, the specificity reduces, because normal placenta sometimes can also be very heterogeneous. T2 dark intraplacental bands and focal gap in myometrium are sensitive, but they are less specific because they can be seen in other conditions, or they can be just normal findings. All right, bladder tenting also has got an 80/80 specificity and sensitivity. So this is an example where these are two different patients, okay? Both are done around 30 weeks. And in this case, you can see that the placenta is a bit heterogeneous. And there are just one intraplacental dark band, and this is a placenta previa as well. And because in third trimester, the lower segment is normally very thin, so this was initially diagnosed as a normal, no evidence of placenta invasion. However, during surgery, it was confirmed to be placenta accreta. All right. So, and this patient here, similar findings are seen, and in operation, actually, it turned out that there was no placenta accreta spectrum at all. It was just placenta previa and no placenta invasion. So it tells us that it is actually can be quite difficult in certain cases when the signs of placenta invasion is not obvious. It is a combination of all the signs. The more signs you get, then the more likely we will be seeing placental invasion. So with only one or two signs, then it becomes not so sure whether the MRI is, whether there is a PAS present. So key points here, ultrasound is the primary imaging for assessment of PAS. Both ultrasound and MRI show comparable accuracy in the diagnosis of PAS. MRI is a problem-solving tool when ultrasound is equivocal or to assess areas difficult to visualize on ultrasound. It should not be used routinely. So MRI should be done between 24th to 30th week of gestation when the placenta is mature and its appearance is relatively stable and predictable to increase the diagnostic accuracy. And it is important to note that a negative MRI does not exclude PAS, okay? In cases where ultrasound and MRI are in conclusions differ, then treatment planning generally errs toward anticipating the gravest diagnosis. Thank you.
Thank you, Dr. Erica, for a very detailed explanation of the imaging of placenta accreta spectrum. And now that we've heard the MRI finding of this patient, I'm sure all of you will agree with me that this is not an easy case for us to manage alone. So we actually sought help from our intervention radiologist, and I would like to invite Dr. Aidi Asmadi. He is our intervention radiologist to enlighten us more on the procedures that was done in this patient. Over to you, Dr. Aidi.
Thank you. Assalamualaikum warahmatullahi wabarakatuh and a very good morning. Can you see my slide and hear my voice?
Yes, Dr. Aidi.
Okay, thank you, Prof. So basically, I'll be talking about my name is Aidi. I'm the interventional radiology fellow. I'll be talking about the role of intraoperative temporary balloon occlusion for of the internal iliac arteries in the context of placenta accreta spectrum. Okay, so as have been mentioned by the previous speakers, the placenta accreta spectrum is abnormal invasion of placental tissue and can be graded into accreta, increta, or percreta depending on the degree of invasion. So this condition carries a high risk of catastrophic hemorrhage, and by catastrophic, I'm talking about liters and liters of blood oozing out. So it's usually managed by elective C-section, cesarean hysterectomy or C-section. So several approaches have been done to reduce intraoperative blood loss, classically including backfilling of the bladder, clamping the cervix, and internal iliac artery ligation. So as far as the where does the interventional radiology falls into this? So we have adjunctive or approach which are endovascular to so hence minimally invasive, which includes internal iliac artery balloon occlusion. So what's the rationale behind internal iliac artery balloon occlusion? So the placenta receives its maternal arterial supply mainly from the uterine artery, which in turn comes off the internal iliac artery. So a quick anatomy revision. So from the abdominal aorta comes down into the common iliac artery, and that's the external iliac artery. But we are more concerned or more interested with this particular fellow here. So the internal iliac arteries. And so the internal iliac artery, which comes off here, then it goes to supply your uterine and your vaginal arteries, which in turn supplies your placenta. So the placenta into the arcuate arteries and the radial arteries and eventually into the fetus. So as it receives its maternal supply mainly from the uterine artery, and it carries and the placenta accreta spectrum carries a significant reach of catastrophic hemorrhage. This procedure utilizes a balloon to temporarily occlude the internal iliac artery to stem blood supply to the placenta, hence reducing the risk of hemorrhage. So how is it performed? Well, initially we need arterial access to introduce our balloon. So it's commonly done via the common femoral artery, and an arterial sheath is then placed within the femoral artery. So on the morning of the delivery itself, patient is initially first thing in the morning sent to the NG suite, and we perform a femoral puncture. And through that, we place an arterial sheath, which allows and maintain arterial access without blood coming out all the time. So we puncture under ultrasound guidance. So that's our needle there going into the femoral artery, and we puncture around this region here, okay, at the groin region. So there's an arterial sheath. The green part there is the valve that prevents blood from hosing out all the time, but it allows introduction of endovascular devices. So before putting in a balloon, we put a diagnostic catheter inside. We advance it into the contralateral side. So if we puncture on the, if we want to put the balloon on the right side, we will puncture on the left femoral artery and left common femoral artery and advance the catheter into the contralateral side. So I'll just show you a quick video. Okay, so that's our catheter there coming off from the left side into the common femoral artery, into the common iliac artery on the right side. And that's the angiographic run. I think you can appreciate that's the external iliac artery. And coming off, that's a fairly elongated internal iliac artery. And as you can probably appreciate, at the low segment there, there's a lot of tortuous vessels that's most likely supplying the placenta. Okay, so again, so that's the catheter tip going into the right common iliac artery, and that's the external, and we're more interested with the right internal iliac artery at this point in time, okay? So using this particular image, we can measure the size of the balloon that we need. And a balloon catheter is an advanced and parked within the internal iliac arteries. So we can then perform test inflation under fluoroscopy. So that's a balloon catheter. At the distal end there, we can proximal end there, we can see a hub, two hubs, one for balloon inflation and another one to introduce our guide wire. and the balloon is actually just at the distal tip of the catheter. It comes in deflated state, so we will after putting the balloon where we intend it to be, we can then inflate as per the pressure that is prescribed. Okay, so this is just another video. You can see, I hope you can see the balloon. Those are the two markers, proximal and distal marker. We are advancing the balloon into the internal iliac artery. I'll just show you again. So the catheter. Oh, the video is not playing ball. Oops. Sorry. Okay, and then we can inflate the balloon. So, and then the procedure is repeated to advance another balloon from the right femoral artery to the left internal iliac artery. Okay. Again, we perform an angiogram. Okay, that's a left internal iliac artery. And we advance the balloon, and again, we test inflate the balloon according to the size required. So, and afterwards, we deflate. Apologies. And after that, we can deflate the balloon, and the balloon is secured externally to the skin, and this is to prevent the balloon from being dislodged from the internal iliac arteries. So the patient is then sent to OT and baby delivered, and upon receiving cue from the obstetrician or the surgeon, the balloon is then re-inflated in OT. Okay, knowing well that the balloon is in the internal iliac artery. So that's the setup. So the balloon actually, part of the balloon is actually inside the patient, while the balloon catheter and the balloon itself is within the internal iliac artery, and it's connected here to two inflation devices. So that's the inflation device, and if we zoom further in, we can see that there's a gauge there depicting the pressure that is required to inflate the balloon. So in terms of evidence, without being biased, there's some evidence that says actually it doesn't really help in reducing the number of transfusion. However, if we look into the systemic review and meta-analysis, we can see that this particular one looks at 29 articles, looking at total sample size of nearly 2,000 plus. It shows benefit in reducing intraoperative blood loss. Okay, as I think it's shown in this particular case. So what are the alternatives to temporal endovascular alternatives? So we some centers do aortic balloon and common iliac artery balloon instead of putting it into the internal iliac artery. But of course, this carries other risks. So in terms of aortic balloon, you are occluding a very large vessel, and that I don't think the anesthetist will be happy with you. And the common iliac artery balloon that carries the risk of causing problem to the vessels that goes to the limbs. So that's another risk to think of. And other things that we could do is uterine artery embolization, which can be a bit more permanent. Okay, thank you.
Thank you, Dr. Aidi, for educating us on the internal iliac artery balloon occlusion. And I think we've heard from the first presenter, Dr. Rafi, that we had no choice but to perform a hysterectomy on this patient because intraoperatively we can see that the placenta is already bulging out through the serosa. So with that, I would like to invite Dr. Lai Ming from the Department of Pathology to talk more on the histological finding. Over to you, Dr. Lai.
Thank you for the ONG team to invite us on the discussion of the histopathology examination. I'm sorry that my professor, Dr. Dashima, wasn't able to attend on this meeting. I'll proceed on the histopathological examination. Just before that, we just like to give a brief histology view on how a normal placenta and versus a placenta accreta spectrum. So if I could orientate you, so this would be a normal myometrium layer where at the placenta implant adherent site, this is the decidual plate. We will divide on will be serve as a barrier on the muscle and the chorionic villus. And in placenta accreta spectrum, where in this condition, we will lose of the decidual layer, which is this part in between the villi and the myometrium. So on pertaining of this patient, thanks for the intraoperative team giving us a full bulk of the placenta in situ with the uterus. And thanks for the clinical suspiciousity written on the request form, we were able to examine once we were able to inserting a probe to biwaft this specimen into two, and then we will examine on the placenta location on the specimen. So as you can see, this is the endocervical os, where this placenta has covering part of the endocervical outlet. So, and then with this, this is the normal myometrium with the endometrial layer thinly here. And you can see the placenta bulk actually is actually adhere very near to the to the myometrium, and somehow it's like approaching the serosa layer, but you still can appreciate the normal stiffness of a thin layer of serosa over here. So thus, we will section the thin area as well as the neural area to assess on histology macroscopic. So over to here, we can already confirm the diagnosis of the placenta previa. The second one, we need to raise the suspiciousity of the placenta accreta spectrum here. So over the macroscopic, we will try to attempt on a gentle traction to see whether the placenta bulk will able to remove or not. If it is strongly adhere, not removable, then we will section that area to look for even microscopic evidence of the loss of the decidual layer. So this is the lowest magnification that we can go. So this is the myometrium layer. So over here, this is the chorionic villi. And we can see there is loss of the decidual layer. As we can see, this extravillous trophoblast is already at the myometrium layer without the intervening decidual. So again, this is another view where the chorionic villi and the fibrin formation with the extravillous trophoblast present on the myometrium fibers. So this is another two close-up view showing similar condition. This is the fibrin layer in between, and this is the higher magnification of the chorionic villi at the fibrin layer, and it was just superficial to the myometrium, where in between there's presence of extravillous trophoblast, in evidenced by this hyperchromatic nuclei. And this can even further prove by the presence of by using the immunohistochemical stain, where this is a cytokeratin. You highlighted the syncytial cytotrophoblast as well as the extramillus trophoblast. So we can see the brown staining was the positive marker, and it was invading to the myometrium. So just on abnormal plantation, where this is the placental bulb was adherent to the uterine wall, it was called AIP. It was the traditional term that used for indicating placenta accreta, increta, and percreta, which is corresponding to whatever the new term using, which is placenta accreta spectrum. So for accreta, the villi is implanted on the myometrial surface without the intervening decidua, but the myometrium wasn't thinned out. In increta, the villi extend into the myometrium with thinned out myometrium. Percreta, it happened where they already penetrate the entire myometrium thickness and through, and we can see through into the uterine serosa. So our final diagnosis would be the placenta increta, as there's no evidence of microscopic perforate through the serosa layer yet, with the underlying placenta previa. I think that's all from the pathology team. Thank you.
Thank you, Dr. Lai, for explaining to us about the microscopic and also the microscopic finding of placenta accreta spectrum. And I think for the next presentation, I would like to invite Associate Professor Dr. Ng Beng Kwang to talk more on the placenta accreta spectrum. Talk about more in terms of the challenges in diagnosing it and also the controversy in terms of its management. Over to you, Dr. Prof. Ng.
Thank you, Prof. Azula. Thank you all the speakers who joined us today morning. I'm Dr. Ng here from ONG department. Today I'm going to talk to you regarding placenta accreta spectrum overview in the pregnancy. So this is the content of my talk today: introduction, epidemiology, pathophysiology, risk factor, diagnosis and management strategies. So as we know, the placenta accreta spectrum, also known as abnormally invasive placenta or morbidly adherent placenta, is a clinical situation where the placenta does not detach spontaneously after delivery and cannot be forcefully removed without causing massive and potentially life-threatening bleeding. This should be differentiated from the retained placenta, in which the whole placenta have detached but retained in the uterine cavity. According to the depth of trophoblast invasion into the myometrium, we know that we have placenta accreta, increta, and percreta. So if you see the FIGO classification, grade 1, grade 2, grade 3, basically it's all under placenta accreta spectrum. So perhaps for those that want to learn more about this placenta accreta spectrum, then you can actually Google this paper, and it's free for downloading, and you can know the grading, the clinical features, and as well as histologic features. So about the epidemiology of the placenta previa accreta, from this recent paper published in BMJ Open, we know that the prevalence is around 0.05% to 0.2% in the general obstetric population. However, in the cohorts with placenta previa, the risk of placenta accreta will be higher. And we see here between 5 to 70%, obviously due to the numbers of cesarean sections that will come to you later. So several theories have been proposed to explain why and how PAS occurs. The prevailing hypothesis is that an iatrogenic defects of the endometrial myometrial interface that leads to a failure of normal deserializations at the site of uterine scar, enabling the abnormally deep trophoblast infiltration. We also know that the decidual potentially regulates the trophoblast invasion. So any disruptions of the decidual, for example, after previous sections, may result in loss of inherent regulation and uncontrolled invasions of the extravenous trophoblast through the entire depth of the myometrium. And we also know that the extent of penetration of the venous tissue within the myometrium is likely to be related to the degree of decidual myometrial damage. For example, if underwent a MRP, manual removal of placenta, uterine curettage, and endometritis, are probably likely to result only in the abnormal adherent placenta accreta, but a full thickness surgical scar in previous sections will result in the endometrial reepithelialization and vascular remodeling around the scar area, and this may lead to abnormally invasive placenta, which is a more severe form in creta and percreta. PAS may occur after any kind of procedure that cause damage to the endometrium. We know that sections is most important factors. Other risk factor includes curettage, manual removal of placenta, uterine artery embolizations, myomectomy, advanced maternal age, high fertility, and even IVF will increase the risk of placenta accreta spectrum. So as mentioned, the major risk factor for PAS is a prior section delivery in combination of placenta, in combination with placenta previa. The risk of PAS increases progressively with the increasing number of section delivery. The risk of placenta accreta in the placenta previa patient is 3.3%, and the risk increased to third seizure together with placenta previa and 61% with fourth seizure with placenta previa. However, if you don't have previa, with the increasing number of sections, will also increase the accreta, but the overall risk is still small. For example, if you don't have previa, you have one previous section, you only have risk of 0.03%. With two previous seizures without previa, the risk of accreta is 0.2% and is continuing like this. So we're not only talking about placenta accreta, we're talking about the morbidity with this placenta accreta spectrum. Obviously, you can see here with the placenta accreta spectrum, the risk of bladder injury is significantly higher, needs of ICU care, the need to reoperation again, and those placenta accreta spectrum patients that require hysterectomy. And now we are talking about the risk of hysterectomy again, the risk of bladder injury, respiratory injury, again, ICU care and reoperation is significantly higher. So a lot of patients asking me and training asking me, is IVF increase the risk of PAS and why? Perhaps the answer is yes, because the aberrant placentation may be the effects of elevated serum estrogen at the times of embryo implantation, which may lead to excessive trophoblast invasion through the endometrium. Another explanation is that the lower serum estradiol level, together with the presence of a thinner and decidualized endometrium, may result in abnormal trophoblastic growth leading to PAS. So IVF increase the risk of PAS? The answer is yes. We know that accurate antenatal diagnosis of PAS has been demonstrated to improve the maternal outcome, allowing appropriate risk assessment and planned delivery in the tertiary referral center with an experienced multidisciplinary team. So antenatal diagnosis can reach up to 95% in the series from experienced centers, but several population studies still claim that the PAS remain undetected before delivery in half of the case in the overall population. So they still miss the placenta accreta spectrum. And we can make the diagnosis based on the ultrasound finding, MRI, and clinical diagnosis. So what are the ultrasound findings? The unified descriptors that are suggested by the European Working Groups on Abnormally Invasive Placenta show that the loss of clear zone, in which we have found loss of irregularity of hypoechoic gland in the myometrium underneath the placenta bed. So there's a loss of clear zones. There's abnormal placenta lacuna presence. The bladder wall interruption, in which we can't see the nice line between the uterine selosa and the bladder lumen, as well as myometrial thinning. And we found that thinning of myometrium overlying the placenta less this can be confused to due to the myometrium thinning, due to the lower segment also become foul, in which you can see the deviations of the uterine scenario in which the bladder is involved. You can see the focal esophageal mass that protrude into the bladder. So you can see here the loss of interface between the bladder and the uterus. You can see a lacuna presence. Okay, you can see some loss of the clay zones here at the bottom of the picture, and the worst scenario at the right side of the picture is the esophageal mass that's seen in the bladder. So how about the use of Doppler ultrasound, the 2D Doppler ultrasound? So it helps also because you can see the uterosacral hypervascularity. You can see a striking amount of color Doppler signal seen between the myometrium and the posterior wall of the bladder. And we also can see subplacental hypervascularity. And we are lucky enough, we can see a breathing vessels from the uterus go into the bladder. And we can see also the placenta lacuna feeding vessels. Besides seeing the lacuna, we can see a lot of high vascularity in the lacuna legs. So from the first picture on the top left, you can see increased vascularity. You can see some vessels, breathing vessels go into the bladder already. And the worst thing, you can see a lot of very angry, huge tortured vessel in the lacuna, as well as overlying the placenta area. The use of 3D ultrasound, the features almost same like the 2D color Doppler ultrasound. So how is the performance of ultrasound in the third trimester? So this is a very good paper published recently in 2022 regarding the use of ultrasound to diagnose placenta equina. You can see here, there's total 84 patients that are included in this study, and 42 diagnosed antenatally, 41 is true positive, but one only is false positive. But patient ended up with hysterectomy also because of bleeding. 42 was not diagnosed to have placenta equina, but there's a false negative of 10 patients, and 6 turned out to be inquita and 4 turned out to be perquita. So this gives us around the sensitivity of 80% and specificity of 96%, and the diagnostic accuracy around 87%. Of course, different series will give you some slightly different in terms of sensitivity and specificity, but the performance of ultrasound is somewhere there. So what also important that we can see, compare patient with placenta equina spectrum and without placenta equina spectrum, the presence of lacuna, okay, the increased vascularity, the breathing vessel, the lacuna feeder vessels, these are all that we found is more significant in PAS patient compared to non-PAS patient. Thank you, Dr. Alika, that mentioned about the use of MRI. We know that MRI definitely has a role in the diagnosis of PAS with high sensitivity and specificity, but unfortunately, MRI has not demonstrated to be more superior ultrasound in the diagnosis of PAS so far. And don't forget that most of the time, initial screening with ultrasound, we ask for MRI. But so this might be actually leads to the overestimation of diagnostic capability of MRI. But MRI definitely have the role in terms of to assess the depth of invasion and the extension of myometrium invasion, especially with posterior placentation, and women are role here for the use of MRI to assess. For ONG training, you might want to look at this paper to tell you know more about MRI sequencing, what we order, what we see, and the MRI finding. And this is free for downloads also, a step-by-step approach to understand more about MRI. So the paper is free for download. So this is good for ONG training as well as radiology training. So in all cases of antenatal suspicion, as ultimate confirmation of this condition should always be undertaken intrapartum before surgical treatment is commenced. Unfortunately, there's no robust evidence demonstrating AS, a stepwise process. So what we do, step 1, uterus and the pelvis for frank signs of placenta invasion. This includes the abnormal appearance of the uterus over the placenta bed, whether we can see some bluish or purple appearance with evidence of distension in which we can see the placenta bulge. So the first picture on the left is the patient that having the same problem, placenta equita, 1 month before our current case. So this is another case 1 month before in our current case. So of course, you can also see obvious invasion of the placenta tissue through the surface of the uterus, with or without invasion of the selosa. So you can see very angry, huge vessel. Okay, you can't even see the myometrium now. It's all about the placenta and huge vessel. Step 2, if there's no clinical evidence of the most invasive forms, this is what normally happens. The uterine incision should be made to leave the placenta undisturbed. So we try not to cut the placenta, and gender cord traction can be attempted. If the traction on the umbilical cord causes uterine wall to be visibly pulled inwards in the direction of the traction, with no separation of the placenta, what we call the dimple sign, then PAS can be diagnosed. But I highlighted in red color here because we knew that one of the cornerstones of the management of PAS is to avoid any attempt to remove the placenta, either in the conservative or in the radical approach. In an abnormally invasive placentation, any attempt to be forcibly remove the placenta will leave the placenta fragment within a very deficient myometrium and result in an uncontrolled major obstetric hemorrhage. So we normally don't do control cord traction. After assessment pre-operatively from the imaging, from the risk factor, intraoperatively, we see the evidence of invasiveness of the placenta. If there's no in the step 1, then in the step 2, we usually use the HEMA beds intra-umbilically. Surprisingly, with the use of intra-umbilical HEMA beds, okay, it caused a very huge, very strong placenta contractions. And if there's no equita in the case, the placenta will come out nicely, even within 30 seconds. So if there is no PS not been diagnosed by the previous 2 steps, then of course, this might not a placenta equita. So then you might want to do a gentle digital exploration, try to assess the presence of plan of cleavage between the uterus and placenta. So the management strategy, there's no huge nice paper to tell you what to do, because due to the relative rarity of these conditions and given the ethical issue that randomized control trial would face high quality study dealing with the management of PAS, they also are still lacking. So we know that the death of placenta invasiveness is one of the major factors that affecting the maternal outcome. Thus, the correct assessment of the degree of the invasion at the time of delivery, the stratifications of women according to this, and the precise correlation between prenatal imaging, intraoperative, and pathology aspect are of utmost importance. So there are 3 management strategies here. First is traditional surgical management. We have delayed hysterectomy, and we have conservative management. So what is traditional surgical management? We knew that cesarean hysterectomy is considered to the gold standard for the treatment of invasive placentation. So this is a specimen for this current patient that we discussed today. And almost 80 to 90% of antenatally suspected case of PAS underwent cesarean hysterectomy. So what we do during a hysterectomy, a vertical incision, skin incision is a preferred option. Of course, you can go for malar incision, but a vertical incision is allowed you to have adequate access to the uterus and even the pelvic side wall. Okay, uterine incision should be performed avoiding the placenta transection. Try not to cut the placenta if possible. This helps to reduce the blood loss from the placenta bed. So what we do from the ultrasound before the surgery, we try to locate where is the bulk of placenta. Okay, what is the area that have the thinnest parts of placenta, and we'll make the decision over that area. After delivery of the 5th infant, then the uterine incision will be rapidly closed and the hysterectomy will be performed with a normal manner. So with the use of internal iliac artery balloon catheterizations, it really helps to reduce the blood loss. So of course, the risk of cesarean hysterectomy that mentioned before, the risk of urinary tract injury is up to 30%. This is particularly true and for the bladder injury can be up to 76%. Of course, the risk of bladder injury also depends on which type that you deal with. Is it equita, is it inquita, or even perquita? Perquita has a higher risk of bladder injury. Urinary injury is something that not uncommon, also 70%. The risk actually depends on the depth and extension of placenta invasion. Of course, the intraoperative blood loss, when you have severe bleeding, okay, you will obstruct your surgical field, then you tend to cut your friends, the ureter, or injured other organs. The less common injury includes the bowel or pelvic vessels. So what is delayed hysterectomy? So this is an alternative radical surgical management strategy for PAS. This involves the delivery of the baby, then closure of the uterus with the placenta left inside too, and closure of the maternal abdomen. Okay, so then a planned hysterectomy can be carried out 3 to 12 weeks postpartum, because the uterine perfusion reduced after delivery, even with placenta inside too. And the involution of the uterus and reduction of the vascularity will definitely make the later surgery less risky for the woman. Okay, so third approach will be conservative management. So this will be any approach whereby hysterectomy is to be avoided. So we might want to consider in 2 circumstances in which intraoperative findings suggest that hysterectomy will be likely complicated and associated with high risk of massive hemorrhage or adjacent tissue injury that may be reduced by leaving the placenta inside too. Second, women who desire for future childbearing. You might have one patient, 23 years old, one previous scar only, but end up with placenta equita. So when the woman who desire further childbearing, then you might want to consider conservative management. So what happens in leaving the placenta inside too? The umbilical cord is ligated close to its placenta insertion after delivery. Without any attempt to remove the placenta at all, the placenta is left inside too. So some studies have been actually suggest some adjunctive measure to reduce blood loss and to speed up the process of placenta resorption. For example, the use of MTX methotrexate, but unfortunately, the use of methotrexate will link to a maternal death in the largest case series. The use of compression suture might lead to the uterine necrosis. So what is more commonly practiced is post-operative antibiotic therapy. We usually prescribe to minimize the risk of infection. So we expect the placenta expulsion or resorption usually take from 4 weeks to 9 to 12 months, with a median of 13.5 weeks. Success rate around 78%. Of course, it can range from 30 to 96%, and with some severe maternal complications, for example, sepsis, uterine necrosis, postpartum uterine rupture, fistula, APO, renal failure, VTE, and even maternal death. So this is one series that published recently. The series, the successful range from as low as 30% to 96%. Then you can hang around 78%. Another series in terms of conservative management to leave the placenta inside too, the success rate only around 15% to 58%. So what is the worry about leaving the placenta inside too? So we are talking about the morbidity or the complication, possible complication. You can see here the patient that requires transfusion is up to 41%. The unit of PET cell required more than 5 is 15%. So the need to transfer to ICU up to 1/4, the risk of infection 28%, the risk of septic shock sepsis up to 4.2%, uterine necrosis 1.2%, and secondary postpartum hemorrhage up to 10%, and the patient subsequently require delayed hysterectomy up to 10%. So subsequent pregnancy have been reported in the regions of 89%, surprisingly, for women who are attempting to become pregnant again while leaving the placenta inside too. Of course, we have the risk of recurrent PAS 30%, in which this time she might have experienced a more major hemorrhage or even maternal death. So women must be appropriately counseled about the risks and the needs for potential lengthening follow-up in a center with expertise if you decide for conservative management. To my knowledge, so far in HUKN, we never practice conservative management. We always go for the primary section hysterectomy in the case of PAS. So from these 3 approaches, primary hysterectomy, delayed hysterectomy, and expectant management, all come with advantage and disadvantage, and this should be properly counsel the women. What is another possibility? The local surgical extraction. Sometimes the placenta equita is just the focal equita, not the entire placenta that's stuck to the myometrium. So for focal disease, which an adherence of invasive of area is less than 50% or anterior surface of the uterus, you can actually just do the local surgical extraction. You cut the placenta tissue together with myometrium, something like we do a myomectomy and repair the uterus straight away. This helps to reduce blood loss and improve maternal morbidity. So something about the intrapartum use of prophylactic endovascular balloon catheter. Thank you, Dr. ID has mentioned about this. So that this might not be useful. But the recent systemic review meta-analysis that published 2021 or 22 here, 29 article, the sample size for balloon occlusion up to 1,225 and the control group up to 1,140. And it showed that the mean blood loss, intraoperative blood loss, have been significantly reduced from 1,430 cc to 400 cc only by the use of internal iliac catheter balloon. And the risk of hysterectomy also reduced significantly from 8.9% versus 31%. So if I conclude my talk today morning, PAS is potentially life-threatening condition. Given the increasing rates of C-section worldwide, the incidence of PAS will be likely to be increased further over the time. Clinicians should be aware that difficulties related to the diagnosis and challenges associated with the management of this condition. Multidisciplinary team approach is definitely the answer here, that we need our radiologists, our intervention radiologists, our anesthetists, our neonatologists to help in terms of managing this patient. With that, thank you for attention. We are happy to go for Q&A session.
Thank you, Prof. Feng, for the comprehensive explanation on the placenta accreta spectrum. Now that we come to the Q&A session, I think without wasting any time, I can. There's a question in the chat box that I think this Prof. Feng would be the better person to answer. Good morning, doctor. May I know what is the indication for the classical cesarean section? How is it different from the lower segment cesarean section? Thank you.
Okay, thank you for the question. We know that the usual one that we do is lower segment section, in which the horizontal incision on the uterus at the lower segment. This is compared to the classical cesarean section, in which this is a vertical cesarean sections at the upper segment of the uterus. So what are the indications for classical cesarean section? Usually there's a few. One, we know that we always try to go for lower segment if possible because of the reduced blood loss, thinning as compared to upper segment, so easier to repair. Then patient can go for trial or scar after a lower segment cesarean section. But in the case of lower segment, you can't approach because of the previous Caesar, very dense adhesions, then you might want to go for upper segment. Second, in terms of placenta previa, placenta accreta, like in this kind of case, you know that the main part of placenta at the lower segment already, so the placenta is very thick, very vascular, and you don't want to go for lower segment. Then you will go for vertical incision again to avoid cutting through the placenta. Maybe the third indication for classical Caesar is those with leaking liqua transverse line that I can think of. So in that kind of scenario, transverse line, leaking liqua, the baby is impacted inside uterine cavity already. Lower segment will definitely give you a very huge challenge to deliver the baby. So in this condition, then you might want to consider classical Caesar, vertical incision again. So for those that underwent vertical incision, classical cesarean section, unfortunately, you cannot try for vaginal delivery anymore already. Okay, hopefully you'll get the answer.
Thank you, Prof. I think there's a question for Dr. ID. When is actually the best time to refer to intervention radiologists for suspected case of placenta accreta spectrum? And can we refer the case on table if there's bleeding?
Yeah, thank you for the question. In this particular case, I think it's usually managed electively in the sense that we plan ahead all the when the date of the season and everything. So it's ideal if we get a heads up as well. But if, say, for example, there's a unsuspected but suddenly on table there's placenta accreta spectrum, and there's a risk of bleeding, we will need the fluoroscopy unit in order to do our procedure. So it will be a bit tedious in that sense. So as I think as all the panelists mentioned, advanced planning is crucial in managing this particular condition. But yeah, if there's any bleeding on table and it's not you can't stem the bleeding we will be, hopefully be able to embolize the thing a bit later.
All right. Thank you, Dr. Aidi. I think we are running out of time. Let me check whether there's. Sorry, there's another question. Doctor, if the patient already had cesarean section, what is the plan for delivery for the next delivery? I think that one Prof. Ng has already mentioned that once you already have the classical cesarean section, so the next one would definitely have to be another Caesar. All right. Okay. I think we're running out of time, so I'd like to conclude the presentation for this morning. First of all, I'd like to thank all the speakers, all the 5 speakers for the excellent presentation. And to summarize, to wrap up things for this morning, just want to highlight that it's important for us to recognize or have high suspicion of placenta accreta spectrum in those patients who already have the risk factor. All right. And I think for the ONG side, previously we used to send our patient for MRI after 32 weeks.
Yeah.
After hearing Erica's presentation, I think we would change our practice and send or request for the MRI much earlier if we suspect there's any placenta accreta spectrum in this patient. And as Prof. Ng has highlighted, it is important that this case, such case should be managed as a multidiscipline to ensure a better outcome for both the mother and also the fetus. I think with that, we wrap up the whole presentation. Thank you to all the speakers and thank you everyone for logging in. I hope that you've learned something. I think there's a Kahoot game after this by Encik Bukhari. So do log in for that Kahoot. Over to you, Encik Bukhari.
Okey, Prof. Terima kasih.
Prof. Azura,
Prof.
thank you for the
Azura dan Prof.
speaker.
Minghan. Okey, saya akan start poll untuk medical student. Boleh. Semua pun boleh join.
Thank you.
Okey, saya akan kongsikan QR code QR code untuk CPD point. Okey, kita bagi masa 15 saat lagi untuk kita akhiri kuis ni 10 saat.
Thank you Bu Khairi, thank you Aisyah. Bye bye.
Thank you semua. Hello. Salamnya. Cikgu yang mana?